Today, we're going to discuss aortic stenosis. We'll discuss the etiologies of AS, anesthetic management of the disease, and the rationale behind it, as well as some key echo values for you to be attuned to when reviewing your patient. In discussing the etiologies of aortic stenosis, the two most common categories are calcific AS and bicuspid AS. Calcific AS typically stems from hypertensive and similar pathologies as CAD. As you know, bicuspid AS is the most common congenital abnormality. Typically, as is depicted here, two of the cusps are fused, causing the valve to open with a fish mouth appearance. Here we look at the bicuspid valve in the mid-esophageal aortic valve short axis view. We see the aortic valve in short axis and can see the heavily calcified coronary cusps. Outlined on the right image are the two leaflets of the bicuspid valve. This is another view in which we can evaluate the aortic valve. It is the mid-esophageal long axis view. Here we see the LA, the LV, the LVOT, the aortic valve, and the ascending aorta. Also in this view is the right ventricle, not to be confused with a pericardial effusion. When we talk about the hemodynamic management of AS, we talk about a slow heart rate and a high afterload. But why? Well, it all comes down to coronary perfusion pressure. In AS, the LV responds with hypertrophy in order to output against this narrow aortic valve. As the heart muscle thickens, the coronary arteries have more tissue to traverse to perfuse this subendocardium. This subendocardium needs to be perfused in diastole, so a longer time in diastole, aka a slower heart rate, allows for more time for this tissue to be perfused. That explains the slow heart rate, but what about the high afterload? Well, it's related. Coronary perfusion pressure is the diastolic blood pressure minus the LVEDP. As the LVEDP rises in aortic stenosis, DPP must increase to keep the coronary perfusion pressure the same, though ideally elevated to once again perfuse the subendocardium. If you understand one thing from this talk, it would be being able to explain this slide. When we talk about the severity of AS, we talk about some numbers. Aortic valve area is the one that is most often reported and the easiest to remember. Severe AS is less than 1 centimeter squared. Also commonly reported are mean pressure gradients and peak velocity. These last two are related in that the higher the pressure across a valve, the higher the velocity. Some take-home points. Maintain the coronary perfusion pressure by keeping a slow heart rate and a high afterload. If you can explain the rationale behind this, then you've got the basics of aortic stenosis down. Until next time.